Good morning, everyone. To begin with, my name is Dr. Spandana Raila. I'm a pediatric palliative care physician working from Hyderabad. And today we are talking about echo on COVID for people with serious illnesses. And the theme for today is redesigning existing palliative care services in COVID situation, the pandemic, and optimizing the use of our virtual care. And the first session, Dr. Tushar Shah has agreed to do it on optimizing our use of virtual care, organizing teleconsultation and teleprescription. Dr. Tushar Shah is an MD physician, educator, conducts innovative teaching programs for med students and CMEs for a few hundreds of physicians since 2 decades. He has given a series of echo sessions to palliative care doctors on managing comorbidities. He organized the very popular and successful teleconsultation platform during the lockdown with a team of voluntary physicians for continued access to care for the public. And he is Mumbai based. Thank you, sir, for agreeing to do the session in a short notice. So Vinila will share the slides. Sir, do you have slides?
No, sir doesn't have slides. So
okay, sir. Yeah, please go ahead. Over to you.
Yeah, thank you. Good morning, all. I will talk about teleconsultation in general with some specifics towards COVID-19. 2 or 3 rules of teleconsultation that we have learned with some experiences that you must use messaging service while teleconsulting. What I do is when I take a teleconsult, I talk to the patient first and tell him to write down and message or voice message his or her complaints and questions to me first. These come via WhatsApp in India. WhatsApp is the commonest platform for teleconsultation besides the regular phone. So my patients will typically message all their symptoms and complaints, message all their reports, screenshots or photographs of the reports to me on WhatsApp, and then I will talk to them, or sometimes I will just message them for consultation. This saves a lot of time. If I take only calls and try to do everything on calls without any messaging through WhatsApp, I see that my efficiency declines significantly. Using this method during the helpline that we have started in COVID-19, we are 26 of us, we have been managing minimum 200 calls per day per doctor on teleconsults for COVID-19. These consultations can be very brief when somebody just wants to know the preventive measures and we WhatsApp them our written measures, or they can be long when the patient is symptomatic. So this is specific to COVID, of course. But in general, when I do teleconsultation, because now we are in a lockdown and many of my patients are being consulted on the telephone, I prefer to use a medium where I talk, I receive messages, I receive screenshots of reports, I send voice messages and get voice messages. So sometimes we have to teach the patient some part of technology because not everybody knows how to voice message, for example, on WhatsApp. And I think that is one of the most crucial parts of consultation, voice messaging. Video calling is one method which I use least and only when there is need to see the patient for their distress, breathlessness, skin rash, location of abdominal pain, location of chest pain, then I would do a video calling. Otherwise, most of the things are done in these methods. So that is about the modality of conversation with the patient. If I'm doing only a telephonic talk, there are some things that I would like to highlight that we do to improve our diagnosis. As you know, teleconsultation in COVID-19 or otherwise requires a very good history taking. That is a no-brainer. Your knowledge of symptomatology and your ability to inquire about symptomatology has to be perfect. This is what typically happens when I talk to the patient on a phone. I allow the patient exactly 20 seconds to talk. without interruption. 20 seconds, patient should just talk, you should not interrupt. Only the one first question that you will ask him, tell me, what is the problem? After 20 seconds, the patient will start rambling most of the times, meaning thereby that the patient will be distracted to things that happen to him other than his symptoms. Typically, this is how it will go. Dr. Saab, I have fever since 5 days. It comes with chills and I have a lot of weakness and a lot of body ache. And I must tell you that I do not have any dry cough as in COVID, etc. I went to the doctor 3 days back and he gave me augmentin, azithromycin, etc., etc. Now, once he says I went to a doctor, he is now diverting from his symptom. And this is the commonest problem we see. The patient wants to talk about what treatment has been given to him. We do not want to listen to what treatment has been given to him at the beginning because we are still trying to diagnose the problem. And the treatment does not help us diagnose the problem. So the first important thing is after he starts going off track from his symptomatology, stop him. This is an unusual thing. You must interrupt the patient and start asking leading questions. Now that is diverted, you tell him, okay, wait, I still don't know your diagnosis. So wait, now answer my questions. And then there are pointed leading questions which require a short phrase as an answer or maybe just yes and no. For example, in COVID-19, if the patient says, I have fever since 4 days, and then he rambles, you have to stop him. Please stop and answer my specific questions. Do you have a bad dry cough? Do you have severe body ache? Do you have weakness? Do you have diarrhea? Etc. Whatever you want to ask. And then from those answers, you will obviously get your other leading questions. So even though we learn in our college that leading questions are not the best way to interrogate a patient, in a telephonic consultation especially, leading questions have to be pointed and frequent. That is my suggestion to you. Don't let the patient ramble because that will confuse you once he starts talking about investigations and treatment. So that is about interrogating a patient. And one more rule that one must follow, and this is very important, especially in palliative care setup. As far as possible, talk to the patient and not to the relative. First interrogation has to be with the patient and not with the relative, if the patient can talk. So a father will call me saying, my 13-year-old son has fever and cough since 4 days. And then his father will continue giving the history. You will realize that even if it's a 13-year-old boy and you talk to the patient, you will get a different history. You will get a separate set of complaints. So it is extremely important. That is my rule number one, which I teach to everybody during interrogation. Don't talk to the relative first. Tell the relative, listen to him patiently and courteously tell him, may I please talk to the patient? And that is the most important thing. Yeah, so that is rule number 2, talk to the patient. Yeah, I think I can now take questions, and because this is a very long topic, telephonic consultation, we have little time. So if you can just ask me anything that you think are important in interrogation, in symptomatic interrogation and analysis of symptoms. Do you want anything COVID specific? I can tell you that.
Any questions from participants? I think Sir gave an overview of what they're doing practically in Mumbai, and they're supporting patients from all over the country. Anyone wants to question?
Hello, definitely what the sir have shared. I have following the same things nowadays. Actually, I am working for the external OPD in Sipla, Pune. Actually, and we are in some patients we are also asking them to share their photos that we can actually know the what was the condition of the patient. Means addition to this, whatever the sir has told to us.
Thank you, Dr. Sonali. So there are some MCI guidelines out there right now, which we will share with you after the session. And in that, it says that the burden of maintaining records lies on the registered medical practitioner, that is us, who is doing it. So we have to save all the voice messages, all the video messages, the pictures that come, the conversation we have, the e-prescriptions we send. So all these are supposed to be documented on our end to stay protected. Any other thoughts? Any other questions?
Dr. Tushar, during the video conference, is it necessary for the doctor to also come on video? Because, I mean, I prefer to stay on not video for examining the patient, etc. Is that something which is, disturbs the family? Because till now, I haven't asked whether, about their comfort on me not coming on video.
Okay, I don't know can one person be on video and the other not be on video? I don't know about that, unless you keep the camera somewhere distracted. What I'm trying to say is, suppose you're in palliative care, you have a patient with metastatic malignancy, and the patient says that he or she has a severe right-sided frontotemporal headache, excruciating headache, acute onset, first ever episode, 2 days. Now, you know that one of the differential diagnoses of excruciating unilateral headache in an immunocompromised patient is herpes zoster, and the patient may not have seen the rash. You will have to go on video. You will have to look for the rash yourself. So I don't know whether this answer is relevant to your question, but a video conferencing can be mandatory in several situations. We recently had a patient who had severe right abdominal pain, and I had to find out on video whether it was right hypochondriac or right iliac fossa, because the patient was not giving a clear answer, and it turned out to be cholecystitis. So we have to have video in certain situations where you need to diagnose.
I was specifically asking if the doctor needs to go on video. It's not necessary, right? It's not against etiquette.
Doctor needs to go on video. Please explain. Meaning, when I do a video
Like for example, suppose I make a WhatsApp video call, with the patient, I don't have to switch on my video. The patient will have to for showing me the particular problem. So is that against etiquette, or is it?
I'm so sorry. I now understood your question. So I think the important thing about the doctor being present on the video is an extreme sense of satisfaction for the patient. I always see that audio calls give less satisfaction to the patient than video calls. It's like a thing where, when patients tell you, okay, I see you and I get better, that kind of thing. When patients tell us and we feel good about it, well, let them see us on video also. Why not? I mean, I don't know, is that an invasion of privacy? I don't think so.
Thank you, sir. There is one question that says, what about, are these calls planned consultations that you do?
Yeah. So, no, for me, most of my calls are not planned consultations. I run normally without a lockdown, I run an outpatient department which does not have an appointment system. So patients come in and I see them as they come in. So I'm an MD physician and I see a lot of general medicine patients of various varieties. So the patients come with acute pain, and obviously they don't take an appointment when they come in with an acute pain or whatever. So see a lot of acute cases, and therefore by corollary, I don't give appointments on my telephone. They just have to call me. If I'm busy, I just message them that please WhatsApp your complaints, and then I will call you back or we'll talk again. So yeah.
Thank you, sir. Just to move along, I see a few more questions. We will definitely get back to those questions in the chat. But in the meanwhile, we'll start our next topic. It's overview of virtual care scope, approach, and strategies. And this is being dealt by Ms. Camara Van Breemen. She is from Cannock Place, Vancouver. She's a registered nurse practitioner with decades of experience in palliative care. Her background is pediatrics. Thank you, Camara. Over to you.
Thank you, everyone, and good morning. Lovely to see many faces that I know.
Camara, you're muted.
Oh, there I go. Okay. Good morning. We'll start again. Vanilla, I'm assuming you're running my slides.
Yeah, we will be running the
Yes,
slides.
I'll be running the slides. You can just tell me the next slide and I'll change it for you.
Absolutely. So thank you very much. So next slide, Vanilla. So the objectives of this brief topic is just to overview virtual care, an overview of how we in Canada at the center I work at for pediatric palliative care kind of provides virtual care across a large geographic area. We're going to explore the domains of care provided through virtual connections, and I think having more opportunity to discuss kind of the unique issues that COVID brings up in this time. Next. So in kind of exploring virtual care versus telehealth, virtual care really is the broad term that encompasses all the ways that providers interact with patients. I'm actually blocking my screen so I can't see what I'm saying here. And interact with patients to treat and communicate with them and their other care providers. Telehealth is sort of the more limited term that we use to treat common illnesses and is a component of virtual care. Next slide. So how do we do virtual care? Dr. Shah gave a great example of using telephone and WhatsApp and messaging first and before, and then using video. Here in Canada, we use landline or cell phone video links with different platforms, email, messaging, sending photos and video is also part of that. And I don't know if it's true in India still, but in Canada, we still use the fax a lot, believe it or not. And so faxing back and forth information. I think it's important to consider who does this virtual care. So, you know, often we think it's the clinician calling the family and of course, that's very important, but who is the clinician? Is it a doctor, a nurse, a counselor, physiotherapy? I know that in times of COVID now, we're actually doing way more virtual care with our families in Canada through all of those interdisciplinary. I had a child the other day that was having difficulty swallowing, and so the OT did a virtual visit. So I think this idea of who is the clinician engaging and interacting is an important concept. The other thing that happens virtually and is very important is communication between clinicians and other healthcare services and supports. Again, we might engage with a family, but then having to really branch out and provide care through sharing information. And I think the other really important piece that I feel is integral to virtual care is making sure that families have a way to contact us so they can initiate calls and support, and it's not only clinician controlled. Next slide. So here's a map of Canada and India, and I just wanted to point out that the service that I work for is called Canuck Place. We have 2 hospices in Vancouver and Abbotsford, and we do a lot of consultation in hospital. And then the idea of virtual care, this telephone support, this virtual support for families and healthcare providers for 24/7. The little piece of the Canadian flag on the left is where British Columbia is. We have, we're just a little bit smaller than India, but our population is very different, 4.6 million people versus the 1.37 billion that I just looked up on the internet. In our context, which is very different than India, we have about 400 children on our program that receive pediatric palliative care across this province. And right now, again, just an estimate, we do about 150 virtual care visits a month. Although I would say in the last 2 weeks, we're probably doing more than that. Next slide. So I just wanted to break down a little bit. Dr. Shah gave a really good example of how we assess pain and symptoms and really get to the heart of having those conversations with families, which is a skill in of it to itself in terms of providing care through this platform. And I'm going to break it down a little bit more about sort of the care domains that we think about that we provide virtually. The five are pain and symptom management, management of health conditions, family support, complex communication, and care coordination. I'm just going to give brief examples of that. Next slide. So pain and symptom management, we know in palliative care, we have lots of pain and symptom management issues that we need to assess, advise, modify, and give support. I think in times of COVID, we're added another pain and symptom management platform in which we need to explore what's going on with that. Many families will call with those concerns. Often when we're doing a consult on the phone with this, we're really ensuring non-pharm and pharmacological options are known and available. We're planning and anticipating. We might be doing prescriptions, and we're determining sort of the level of intensity of that symptom. What kind of plan do we need to have for follow-up? And then also, when do families phone back with red flags or when changes happen? What could be the care planning around the next phase, whether they're getting worse or better? Next slide. These are two examples that we use to help support this pain and symptom management document. On the upper screen is a comfort log that we will send to families via email or WhatsApp and say, can you track the behaviors or the things that you're observing in your child, the date, the time, and then what is the intervention you do? So is it cuddling? Is it using the fan? Is it giving Tylenol or an opioid? And what was the outcome? And this can be really helpful that we can follow that up and sort of see patterns and things like that, and really be able to track symptoms in a better way. The lower one is just a symptom guideline that I use as an example for a child who has a brain tumor, was experiencing pain, nausea, and vomiting, and it was actually a brain tumor and a spinal cord tumor. And if they had urinary or bowel retention, what is it that we're going to do if they see these things, and providing families this documentation. Our directions around when to call and what to do are right on this guideline in a fairly simple format. Next slide. Managing health conditions, we know as we get to know our patients in palliative care that we're not only doing pain and symptom management, there's things that with their underlying condition that we might be managing, and either because of the health condition or an episodic illness that comes on top of whatever is going on for them. The example I'm using today is of a child who is managing increased seizures and a metabolic condition. And the mom kept describing to us these seizures that looked different than what they usually did. And we encouraged the family to take a video, share that with us. We were actually able to refer and talk with one of the neurologists at our children's hospital, and then get recommendations from him and follow up with mom around these are the things and these are the things we're hoping for. And the video was just such a really great tool to use to be able to really see what the seizure looked like. Next.
Camara, 2 more minutes.
Okay, I'm almost done. Family support. So that's another area of using virtual support, phone, video, messaging, email, all good things. Adjusting to illness and grief and loss. We have counselors that are calling and connecting. We're providing anticipatory guidance about what end of life might look like in care of the body. And interestingly, in this COVID time in Canada, we're actually using Zoom a lot more, even with some of the siblings, to do play therapy. So that's actually been a platform that's worked for many of our families. Next. Complex communication. Goals of care discussions is another aspect that we're using virtual care. What are the goals? Again, we're revisiting what care might look like. When do you go to hospital? When do you don't go to hospital? And this actually is changing in the face of COVID. We provide, recommendations for what is best care, and then also in Canada, providing them with the correct documentation. So if they are comfort focused, if they are wanting intensive care, whatever that might be, if we outlay a plan and provide that in documentation, families have that as a tool that they can present to urgent care to get the care that is really required and in line with their values and goals. And next. And then just that last piece of care coordination across settings. We all do this. We all using, phone calls and faxes for Canada, sharing online if we have e-charts or things like that. It's a big part of, there's the patient engagement, and then there's the documentation and the sharing the information and making sure that families and providers know who's doing what and when. And the next slide. And I'm going to leave it back to Spandana to lead us in discussion and questions around this part of the presentation. Thank you.
Thank you, Camara. So any thoughts, anyone? Anything you want to share? In participants, we see Dr. Mohan from Can Support. Hello, Dr. Mohan.
Hello, good morning.
Hello, sir. Would you like to share about the work you are doing at Can Support?
Yes, at the time of COVID threat, we are doing a home care services, but only visit very serious patients, those who can't be handled without telemedication. We are very, making only few visits. Like patients who need morphine, they are visited. Patients who need some catheter change or things like that. Somebody needs a ascites type thing, one has to visit. So we only visit those patients who cannot be managed on phone or a video call. Conveyance is a problem. We got only few licenses from the police to visit patients. Are all vehicles not plying, and we plan a day before who will be visited. So of course, it's not the ideal situation, but we are doing our services. Home care is on. We do visit very serious patients. We do visit new patients if we feel they can't be handled on phone or through a video call.
Okay, sir. Dr. Biji, are you there? Thank you, sir, for sharing. Dr. Biji. In the meanwhile, we'll see a few questions that have come up. So, Camara, do you have any restrictions for the use of any legal restrictions on video calls?
Well, we do have to be conscious of the platform we use. We have recommendations from our colleges around confidentiality. We also ask parents for consent around using different platforms. What I have noticed, again, in these COVID times, is that our colleges are acknowledging that given that we can't provide care in person to the same degree, that we're taking a little bit more risk in terms of the barriers that we might have had before, because there's a recognition that patients need care, and we almost can use many of the platforms to ensure that they get care. So we're conscious of it. We definitely let parents know that which platform we're using and that kind of thing, and we document that as well.
Thank you, Camara. I think there's one question, Dr. Mohan, for you. How satisfying are these video calls and these audio calls to the patients?
Well, You know, I find it really amazing how much, I mean, I'm working with this family this week that I've never actually met in person. And we've had contact probably 6 or 7 times in the last, well, probably 8 or 10 times with our team in the last week, and myself personally for about 5 times. And what's so interesting is when you really listen to families, similar to what Dr. Shah says, when you really listen and you give that time, and then you kind of whittle down what are the issues that we can help you with, and then you make a change, and the family sees the difference in their child's symptoms, and that you really hear what they're saying. It's immediate. You feel sort of this trust developing over time through the phone, through the video. And I mean, I've been practicing this kind of care for many years, and you know, there is an art to it, and there's a learning curve because it is different kind of care. But what families, I think, appreciate is that they get immediate support, immediate feedback, and they don't feel so alone. Many of our families in BC live remotely, and so they're kind of used to using this platform. I'm not sure how that would be in India as the same, but for sure get a lot of feedback that this is just an incredible platform, so that they don't feel so alone. I'm seeing Dr. Shah nod and agrees with that statement.
Thank you, Camara. We'll go right into the next topic, which is palliative care in virtual care, triaging, timing, and also follow-up system. And the speaker is Dr. Lulu ma'am. Dr. Lulu Matthews is a renowned pediatrician, academician, and former head of the Department of Pediatrics. I'm sure I'm pronouncing this wrong, Kozhikode Medical College. She has also done her PG diploma in palliative medicine from Cardiff, and many of us know her for her pediatric palliative care and also the work she does at IPM. Thank you, ma'am, for joining. Over to you.
Thank you. Good morning, everybody. So Dr. Shah has told us about the do's and the don'ts, and Camara has given us a good structure. But basically, I am here to talk about what we are doing right now in IPM since the onset of the pandemic. You know, the IPM, we are having an OP for palliative care since 1993. Okay, so many years now. And suddenly about 2 weeks back, we were called by the principal and told, please shift out of OPM. We want that premise for COVID patients. So all on a sudden, those who have visited IPM know it's quite a spacious place with plenty of rooms for nurses, doctors, patients, everything. So it was suddenly within about 2 days time, we shifted our OP to a hall, which was being used by the paraplegic patients. But right now we are not having any paraplegic patients. And this is about 1 kilometer away from the normal OP clinic. And then again, we have also been told that IPM structure building could also be taken up for COVID care. That is, if at all the need for reverse quarantine comes. So we closed down our IP, the inpatient facility. And then so we had to make some changes. The changes are the staff is divided into 2 pools, each pool working for 2 weeks. And OP in the new premise works from 9 a.m. to 4 p.m. And each pool of staff has 1 doctor and 3 nurses. And 1 nurse is exclusively for communication over the phone. I will come to it in the details. And 1 nurse and 1 driver ready for any emergency home visit. Because right now we have done away with regular home visits. Okay. So this is what I told you. Our OP, we were having around 40 to 45 OP consultations daily. And suddenly the whole thing was closed down. And mainly the patients used to come from the adjoining medical college, from other peripheral clinics, and also the patients themselves. Now our main medical college itself has been converted into the COVID hospital. So you know the confusion that is existing now. But we are doing a lot. See, in the pre-pandemic area, we have a dropout register. which means suppose I see a patient today and I ask for the patient review on 13th. Finally, when the nurse diary, that is Monday. So 13th, that patient's name will be entered. So we have a list of the patients whom we are expecting on next Monday. So that is known as the dropout register. Now that has been converted into daily call register. Because today, if we open that today's page, we know these are the patients who should have come to our OP. So that is the difference you see here. In the first one, you see the patients in the dropout register. The ticked ones are the patients who have come, and the cut ones are the patients who have not come. So we used to call those patients. Now that register is functioning as the call register. You see the tick mark. That is, those are the patients whom the nurse has contacted, which means all the patients who are scheduled to have a visit on to our OPD, that every one of them is called by the nurse. Okay, so the structure of a call goes something like this. Okay, I am calling from IPM. I just wanted to know how you are getting along. What about your symptoms? Because the case sheet is right in front of the nurse. So the nurse knows what are the symptoms which the patient came 3 days back or 4 days back. So how are your symptoms? And do you have your medicine supply with you? And suppose the patient says the medicines are over. So then we ask them, if they're in a nearby area from the IPM, we ask them whether they have a two-wheeler. Suppose they have a two-wheeler, we ask them to come to the OP, to the present OP to collect the medicine. If not, they're somewhere far away, we link them up with the peripheral link center from where they can collect the medicine. And then morphine. Morphine is the most important, and they cannot buy it from anywhere. So again, depending upon the residents from where they come, we either ask them to come here if they have a vehicle, or arrange for it to be collected from a peripheral center if they are living far away. And again, if they have a vehicle, we ask them to come to our center. So on the other hand, if they don't have, what do we do? See, we cluster all the morphine patients together. So one day, one nurse and a driver goes out and visits all the patients in that locality who are on morphine, and we supply the morphine to these patients. Okay. Then again, this also we use it as a COVID advocacy, because every call, the nurse, okay, I'm sure you have heard of COVID. We talk them about hand washing, about the importance of social distancing, and we again tell them, see, specific group of patients are very prone to develop COVID, and your father or your mother is elderly, that category falls in that age group, or having lifestyle diseases like diabetes, or an immunocompromised condition like a cancer. So you should be very careful. Don't allow any visitors, especially those who have come from abroad. And again, as far as possible, let the patient be cared for by one carer only. And keep a bucket with water and soap at the doorstep. In Kerala, we are having a campaign, Break the Chain. It's very popular. Every house is now having bucket, water, and soap at the doorstep. And we also tell them, whenever anybody goes out of the house, even if to the backyard or front yard, when he comes back, he has to wash his hands properly. And then again, suppose the patient or the proxy, patients now very hardly come to our OP into the proxy. If they are coming to our OP, they should be told about what they expect here. So we tell them, it's not like before. You should not come inside. The chairs are laid down for you in a shady area. The chairs are put far apart. Do not bring the chairs closer than they are. Hand washing is a must. Bucket, water, soap kept there. And whenever the patients bring balanced medicines, they should not be brought into the OP. We have kept a tray there. So these medicines should be dropped into that tray. And again, medicines are given through a window opening. That is again maintaining social distancing. So when they come and see all these, they are also, we hope that they are following the same principles at home also. So OP right now, we are not having any problem because of a dropout register. We are calling all the patients, and definitely the patients also call us if they need us. And home care routine also, usually we have 2 teams in 2 different directions daily, 6 different routes, 12 teams every week. Each route having around 40 to 50 patients. So total 280 to 320 patients at one time. Right now we are having 286 patients. So nurses home care visit each patient once every fortnight. Doctors home care, all the patients are visited. Second visit is made every 2 to 3 months. That is the regular schedule. But now we have only emergency home care visit. And then again, clustering of activity is something. Suppose a patient is on urinary catheter. So again, we look through our chart. So again, in one locality, who are the patients who are roundabout who need a catheter change? We cluster all that together. So a nurse and a driver goes and changes the catheters. And again, the previous day, these patients are rung up and they are requested to buy silicone catheter, because we don't know how long this pandemic is going to last. So we want to have a longer period for them. So morphine clustering and this urinary catheter clustering, that is being done, and that works out very well. And again, during this home visit, the food kit distribution is also being done for those who need food kit. See, this is our nurses home care register, the corner here. So a patient who was visited on 6th of January, the review falls on 2nd of February. That is, so that is also given, So if you go through our route map, which is available with the nurses, today, if you take today's date, we know who are the patients who are scheduled for a home care visit. So the same principle we follow. Every patient is contacted the previous day, because tomorrow if they have a scheduled home visit, today we call them. We explain why we cannot come for the scheduled visit. We assess the need of the patient. All non-medical queries are answered by the nurse. Any treatment related query passes on to the duty doctor. I told you our OP works from 9 a.m. to 4 p.m. So doctor is available in the OP. So anytime a nurse has a doubt, it passes on to the duty doctor. He comes online and talks to the patient or the proxy. The new medicine prescription is given as SMS, not orally. And then again, it's very important, each time we call up a patient, that is documented in the case sheet. At 9:20 a.m., Padmanabhan was contacted. He was not available. His wife was available. Talk to him. The following advice was given. So similarly, for any prescription made also, we document it at once, because as far as we know, it's the documentation which is very, very important in telemedicine. And again, how do we know that these things are going on all right? I told you about the staff polling. So everybody aged above 60, including me, I don't go to OP now. So also Meena and Lissy, who many of you will be knowing personally, they are also on the wrong side of 60. So we don't do that. So how do we know things are happening? Daily we get a feedback report from the nurse, and that is in Malayalam. I have given a transcription. So I know yesterday Dr. Fasana was on duty, staff nurses were Sunita, Ajita, Ambika. Old case, 10 patients visited the OP, new patient 1, ascetic tap was done in 2 patients, called up 10 patients for the OP visit. 3 said they would come to collect medicine from our OP. Then 2 calls were from the patients, and advice was given. And also daily the nurse gives us what is the stock of the morphine available in IPM. So sitting at home, not only myself, and again our secretary, our president, everybody, they know in an emergency 24/7. One senior nurse the call after simple queries, but any symptom control or any other medical problem, the call comes to me. For example, yesterday, day before yesterday night also, I had a call. So I talked to them, and again here also the prescription is given as SMS. And at night, the nurse does not have the case sheet with them. But the morning, as soon as she reaches the OP, the first thing she does is she collects those patients' case sheet who had called up during the night, and whatever was the symptom, whatever medicine was prescribed, and she even writes, contacted Dr. Lulu Matthews, she advised too. So everything is written down. Okay, and video calls, okay, nurses don't take video calls. If at all, if the patient is willing, then only the doctor takes the video call. But normally we find that our patients are not very comfortable taking video call. If at all they want to show us something, they say, okay, I will take the picture and forward it to us. So we can look at the picture and then tell whatever we have to tell about that. Okay, so what are our challenges? We are not able to admit our patients right now because we don't know which way the pandemic is going to take. And fund mobilization is a real problem now with the pandemic on. And we have some concern about the adequacy of PPE. All the major institutions in Kerala, they have a screening done. Every patient is screened at the gateway. We at IPM don't have any screening done. So these are our challenges now. And okay, see, this is a patient who came to us with RTA. And because he had to go away when IPM got shut, then I wanted to see how the patient was getting along at home. So, but I did not tell the mother, I want to see how you are looking after him. Instead, I called the mother and told her, so, I mean, we are so used to seeing Achu. I would like to see him. I mean, then the mother was very happy. And at once she came on video call. So I was very comfortable that the patient and the mother was very comfortable. So I think that is very important. The comfort of the patient or the proxy when you ask for a video call. So I have not set down any do's and don'ts, but I've only talked about what we are doing in IPM right now. And I can take any questions if you have. Thank you very much for the hearing.
Thank you, ma'am. Any questions anyone wants to ask?
Thank you, Dr. Matthews.
Dr. Tushar, please go ahead.
Yeah, I just wanted to ask Dr. Matthews, what is the availability of PPE like, and who supplies the PPEs, or are you financed by private funding agencies also?
Yeah, that's what, we don't have any private funding. I mean, mainly it is the community which supports us. And especially during Ramadan season, we used to get the maximum donation. So now we are really having problem, but the government is supplying us now. The government is supplying us. So all the procedures are done with overcoats on. And again with double gloves, and everybody, all the doctors who work in nurses, everybody in the OPD has the mask on. But when the nurse has to do any procedures, she puts the gown on. The government is supplying it.
Any healthcare workers affected? Any healthcare workers affected by COVID?
No, not so far in our place. That is the reason why we shut down our IPM. Suppose if one of our staff gets affected, we will have to cut down the whole service. And you know, we cater to a large number of population, and we don't want to reach that stage. That is why we have cut down the inpatient facility, because you know most of our patients also have respiratory symptoms. So we don't know where we stand. And again, during the telecommunication, we talk to them. Anybody in your neighborhood who has returned from Dubai, Abu Dhabi, or from the Delhi meeting, so far not even a single patient has said there is somebody. So that means they are hiding it. I'm sure there will be several who have returned from Gulf, and again several who have come back from Delhi. But you know, people are just hiding it. So they don't want to say that. But again, we again repeatedly tell them, okay, they may have come from internationally or nationally, but don't allow any visitors home.
Thank you, ma'am. Thank you, sir, for the questions. We are going to cover a session on PPE, and there is a link that you can access and share your questions so that we can address them better. So there was one question asking about social media confidentiality of the patient. Any thoughts on that? Anyone?
The MCI guidelines clearly talk about the confidentiality. So since Spandana, you're sharing that, I think the anonymity, like even when we are discussing like this, ideally when we share patient pictures, you know, they should be anonymized. And yeah.
Yes, ma'am, I agree. They have used the word misuse of data if we are uploading it on social media without anonymizing. And I also see a discussion happening in the chat about consent.
One more question, one more point I wanted to bring out from the MCI guidelines is that whoever is talking, even from the doctor's team, need to identify themselves, because anonymous calls are it is not supported by the MCI guidelines. So you know, we need to identify our name, our institution and designation, and only then proceed. And the patient has the right and the doctor has the right to discontinue the conversation also.
So the other point in continuation with that is e-prescription should have a registration number of the State Medical Council or the MCI. And also, as Madam said, we can discontinue the call if we think we are not doing the best for the patient through the video call or audio call, and we are seeking an in-person consult. So thank you, ma'am, for bringing those topics up. And regarding, yes, ma'am.
Then I have one more point to make, which I have not fully understood. But the MCI guidelines have listed the drugs for prescription into number of, you know, list A, B, O, and X. So our narcotics fall into X. So what I understand, like I have asked, you know, some other, like even the chemotherapy, the oncologist drugs also fall into X. So I asked the medical oncologist what they do. So they say that they have taken the rule as they can continue the ongoing drug, but they cannot initiate. And I've also asked some of the lawyers about interpreting that particular point. So I'll get back to the group with the correct. So currently as I understand, telemedicine only allows continuing of narcotics. You cannot initiate a new opioid by virtual consultation, as far as the MCI guidelines go.
And I think that is very important point for all of us to know. Thank you, ma'am, for sharing. And one point about consent, the MCI guidelines says is if the conversation is initiated by the patient or if the call comes from the patient side, the consent is implied. If we are doing the consult, then as madam said, we have to introduce ourselves, and it's always better to document it through an audio message or a video message in simple words like I agree to the consult, I consent to this consult. Thank you. And Megan, can you summarize the
Hello.
I think Dr. Lulu madam has something to say.
Hello.
She has raised her hand. Yeah, ma'am, please go ahead.
Hello.
Ma'am, you're muted.
I think it's BG, Leela.
Yeah. See, that's what I told you regarding morphine. Whenever a patient has to be started on morphine as a new drug, we always refer that patient to the nearest link center. To the nearest link center. And only after having seen the patient, somebody starts morphine. We don't start morphine new on a new patient on a tele prescription. We only continue the morphine which is already the patient was getting. Any patient whom he think needs morphine is referred to the nearest link center.
Thank you, ma'am.
Hello.
Yes.
Dr. BG, please go ahead.
BG. Can I have a word?
Yes, ma'am. Please go ahead, Dr. BG.
Yeah. Yeah. I just wanted to talk about how we do our telemedicine in my institute. I'm Dr. BG. I work in Malabar Cancer Center. It's a tertiary cancer center in Northern Kerala. So we usually have our home care service, which is e-palliative home care service. It's a video conferencing with the patients where I don't go for home care, but I sit in the hospital and I do this video conferencing. So before we do this conferencing at the outset, when my staff reaches the patient's home and connects to me before that, we get a written consent from the patient or the relatives that they to do this. And we use our own application, web application, that is with us. So we are safe on that aspect. But right now, when there is this COVID pandemic, we are unable to do this e-palliative care service because we are not able to step out of the hospital for this purpose. So like Lulu Matthews said, we are using the telephone calls.
Sorry, did she get disconnected? Dr.
Yes.
BG?
I think it's not here. Yeah.
Dr. BG has a shaky internet connection and she said it might be difficult for her to speak. But she has worked in, she has done research on this. So that's why we asked her if she could share her thoughts. We will definitely get back to you in our points that have been discussed about her input. Sorry for that. Megan, do you have anything that you want to add?
Yes, I'll say one last word. So one thing that we did identify that we didn't really get to share with you today, and I thank all the presenters because it was excellent, and certainly we always have more ideas for things we want to share than we have time to share. But we did identify one center in Bangladesh that is already using a standardized checklist to document their phone calls, and I just want to share it with you because it's actually quite a good template. Can you guys see that? Somebody just nod or gives me thumbs up.
Yes, Megan, we can see.
Okay. So I just wanted to share one template which I thought probably is very similar to what others are using that we designed for Bangladesh pre-COVID, but could be quite easily adjusted to make a very simple documentation template, which I think is maybe one challenge of how do we keep track of what we've told these patients, and how do we hand that off to our colleagues. So this is what they were using, and you can see there's small numbers for each of the symptoms because they were doing a research study where you code each of the responses and then they're tracking over time how this goes, and they actually just keep it in a book like a bound book, and each page is a new telephone call, and then the book gets passed from duty doctor to duty doctor. Whoever's taking the night calls and has the telephone has this book which contains like the past 500 phone calls, so you know if the patient called last week and then this week again. So I just thought that's the one thing I'll share. I'll hand it back to you, Spandana. I'll stop sharing that.
Thank you, Megan. We are almost at the end of our session. I just want to, there are very few questions I think we missed not answering. There is one comment from Dr. Anil, in palliative care, often patients may not be able to effectively communicate, and we will have to talk to the carers, and a lot of discussion occurs between the doctor and nurses visiting the patients. Yeah, that is true. Sometimes even the calls between the healthcare professionals are considered as telehealth and telemedicine. And Dr. BG has written that we do palliative care home service routinely. It is they have their own web application, so data is safe. We even take a consent before the consultation. Yeah. Thank you, Dr. BG, for sharing that. Any other thoughts?
Dr. Sushma has raised her hand.
Dr. Sushma ma'am, hi. Sorry, I didn't see you. Please go ahead.
So I think it was I missed the first presentation. The second presentation, Dr. Lulu's presentation was fantastic, and I think we have to find out. No single modality will be very weak. That it is the most ideal modality. We have to find out what modality with way how we are doing this. Like everyone is working hard to treat their patients, but this is the time when a patient comes, you have to take care of as a whole that he may not be able to meet you for 2 months. So whenever you meet your patients, the thing that we will not be able to meet for next 2 months and plan care pathway, or we can say that whatever treatment pathway you want to make for 2 months. So that makes a lot of comfort to the patient. I know a lot of people are doing WhatsApp calls, or a lot of telemedicine is now is almost MCI has given go ahead, but our patients are different, and there is every day there is a new learning, and although this is true that we are doing a lot of things in this during COVID period, but still I can say that our 50% patients are suffering. They are unable to get their treatment or care what they want right now. So just a message to all of them that whenever you get to know, or whenever you get a patient from any at home care or in the hospital, just think that you will not be able to meet this patient again for 2-3 months, and plan a care pathway like that. Thank you.
Thank you, ma'am. Yeah, I think a lot of it goes into the planning part of it. So I see that one of you have suggested that we should work more on telephonic conversations. If you people have templates, if you can share that with us, we will make them available to all those who have attended the session. We can mix and match them as we see them necessary, and we can have a standardized form for our own session, our own center. Any other thoughts, any other questions? I think we are at the end of our session. Thank you, everyone. Thank you so much for attending at such an early session. I know it's very difficult, and we are going to come back in 1 week. It's on Thursday morning, 6:30 to 7:30 Indian Standard Time, and we will share with you the details of the upcoming session. This COVID Echo is an initiative of IAPC. And also supported by Towards Cancer Collaboration and Hyderabad Center for Palliative Care. Thank you, everyone. See you all in 1 week time. And we will